I'm going to share my screen and we're going to start with a little let me see. We're going to start with a bit of trivia here to get your juices flowing. And what we're going to do is we're going to open up a poll right now. So a poll will appear in your screen if you are on your computer or on your phone. So Lauren, I kindly ask you to pull up the poll. Let me know when it's ready so people can vote. Here we go. So I'm seeing the live results right now. So the question reads, of the almost 1 billion vaccine doses administered so far, what percentage have gone to high and middle income countries and what percentage has gone to low income countries? So is it more or less 50-50, 85-50? This is great. I see a lot of votes coming in. And although the majority of people seem to be voting for option number 3, which is 96 to more or less 4%, sadly, the people that voted 99.8 against 0.2% are the ones that are correct. So when we look at recent data from WHO and where vaccines have been distributed, around of every 1,000 vaccines, right, only around 2 go to low-income countries. That is astounding inequity, right? And so why this topic now? We can't talk about this topic in this context and not talk about COVID. Definitely over the past year, COVID has ravaged economies, health systems all over the world. It has exposed many vulnerabilities in our society, and it's just that inequity within society has fueled the spread of the virus and really leave us wondering what comes next. There's been clearly a radical uneven distribution of health, social, and economic risks that are associated with the pandemic. And because of these risks, the differences between our societies have become ever more apparent. It has really revealed how unequal our societies are. And when we look at the numbers, right, when we look at illness and death from COVID-19, it definitely has been higher among people and communities that contend with poverty, unfavorable living conditions, unfavorable working conditions, discrimination, and social exclusion. The COVID-19 pandemic has brought renewed attention to these inequities, not just in the US, but all around the globe. Here in Costa Rica, where I live, most people that are dying from COVID-19 are from low-income countries. And this really has led to many ask questions around why are there such injustices still in our global health system? And how do these unjust arrangements and structures came to be? And that's the question we're going to try to ask to move forward better. Health equity as a concept is widely touted as global health DNA, reason to be, right? Ethos. And yet our current pandemic underscores that the field really must do more and we must do much better. So as part of that conversation of doing better, here at UMB, we bring the conversation of decolonization forward. Recently, a group of students from different parts of the world asked this question: decolonizing global health, if not now, when? And this is a publication from BMJ, and I'd like to read this quote from the students. "We see this pandemic as an opportunity to critically appraise what is not working and to offer an alternative vision for the future of global health. Global health needs to be integrated, decolonized approaches, advanced by individuals and institutions that address the complex interdependence between histories of imperialism with health, economic development, governance, and human rights. The global movement to decolonize global health, led by students and other professionals, is one step towards this vision." So in order to understand this in context, we have to go back in time. If we're going to talk about decolonization, we need to talk about the history of coloniality, right? The colonial project, as Europeans power knew them, it was not just only to expand their territory, but actually to settle there, conquer, dominate, right? And this mindset really took off from the big European capitals in Lisbon, Madrid, Paris, London. And the vision was to remove power, right, from the colonized and install new power structures to transfer resources, knowledges, anything, even humans, to the capitals, right? And this was done usually in the name of civility many times, or sometimes what we call progress. And it's definitely, when we see the history of coloniality, it was based on racist ideas and notion of superiority. Sadly, when we look back in our history, we see examples of coloniality in medicine helping out the European colonial project, right? There was a role that physicians and scientists kept, not just in understanding and treating new diseases like malaria that allowed the Europeans to advance into sub-Saharan Africa, right? Or sometimes in Asia, but also the creation of these scientific theories that justified and quote unquote rationalize racial differences and the superiority of white Europeans. And this was all to support these extractive mindsets of things like ivory, slaves, sugar, cotton, rubber, tea. And there was this narrow focus on helping the white European, right? Eventually, from this mindset, it changed in an arc in which from that colonial, right, we went from the colonial to the neo-colonial. And today we see still some spillovers on what that means today. We see spillovers in the form of deficit models when we work in global health, right? And by that, I mean, oh, countries in the global south don't know what they're doing. They need the help of us in order to solve their problems, us being global north. And there's 4 characteristics that usually come out very clearly when we approach global health and in a non-equitable fashion. One of them is it's very top-down. It's very vertical, right? There's little consultation with local communities. And when consultation is in place, it's usually very tokenistic. There's a strong emphasis that there's magic bullets out there that can solve every problem, right? And we forget about the role of the social determinants of health. There's other reasons, and people usually tout these reasons that, oh, this is something that we do for altruistic manners. But health improvement sometimes becomes just a goal for exploitation and profit. And finally, we see still some approaches that follow a neocolonial approach when we talk about health interventions that are used as soft power to gain political and economic influences over a specific geopolitical agenda, right? And I'm borrowing there from the work of Dr. Pérez Escamilla at Yale. So this topic has been touted as hot, in vogue, right? And when we look at the literature, this is a Scopus chart in which we look at the amount of literature being published under health and decolonization or neocolonization. And we can see a clear trend here, right? So people say, oh, this is hot. This will be out in a couple of years. So why even worry? I would kind of push back. This isn't a hot topic. This is a topic that needs to stay. Just like we've been grappling with racism in the US, it's a topic that needs to stay. Just like women have been grappling with gender equity and feminist approaches in all realms of life, it's an approach that needs to stay, right? So this isn't a hot topic. This isn't something that's just in vogue that we're talking about. This is something that we need to really incorporate into our conversation today. But I've also said, oh, this is a new idea. Why come up with it now? This isn't a new idea. When we look at several traditions in the global south, the idea of decolonization has been present beyond just the movement of independence. There's been a lot of light being shed in regards to how do we understand ourselves from the global south in a decolonized way. And these are just a sample of actors like Frantz Fanon, Edward Said, Paulo Freire, Ngugi wa Thiong'o, and Linda Smith, who have written from Voices from the Global South about what it means to decolonize research, politics, education, So it is not something that is new as well. It is not hot. It is not new. It is something that has just recently been incorporated in the global North ethos, but it's something that has been here for a while. So when we talk about global health and decolonizing global health, we need to think about, basically, I've been extracting what we mean by it from these four pillars. One of them, it means to rethink the theories, the process, the methods that guide global health that have gone hegemonically imposed and have gone mostly unquestioned. We've normalized our methods, our processes, our theories, and we stopped questioning them. We stopped being critical with them. The other thing is appreciating that there is distinct knowledge systems in which we can build upon. There's distinct worldviews. There is not just one worldview. The biomedical worldview and knowledge system is just one of many, and we need to be able to complement them. It's also about creating these environments where there's trust and there's the possibilities of creating equitable collaboration and partnerships. We've seen UMB is a great example of how do we do this. So we want to borrow from the UMB experience to share with the rest of the world. And we also see the need to balance power dynamics to reflect shared responsibility. And I've talked about this before, and some people have said, Carlos, this is all very nice. It sounds very soft, though. And I also must be highlighted, though, that decolonization sometimes also entails acts of resistance and opposition, as we saw from the Rhodes Must Fall movement in South Africa a couple of years ago. I hope our following keynote addresses this aspect. We want to be really intentional with our Global Health Summit. And one of the things when you visited the website, you'll see is our statement of intent. What do we want from this summit? We really want this to embody an attempt to establish a productive, action-oriented dialogue towards a new global health field. And we're bringing together practitioners, researchers, educators, students, trainees, stakeholders from different parts of the UMB system and from different parts of other educational systems in order to advance how we do diversity, equity, and inclusion, right? So it's a very intentional attempt. So it was important for me to state this at the opening. As part of that intentionality, we had to do some work previous to the summit. The summit is just the outer shell of what this summit is. But we've been working with summit scholars, which are trainees from all over the world and our different partners, more than 90 students and trainees from 9 different countries, from the 7 schools, pharmacy, social work, nursing, dentistry, medicine, graduate school, and pharmacy have been participating actively in this process. We've engaged 35 faculty members from our faculties and from our partners. And we've engaged 8 partner sites, including students and faculty from those partner sites. So when we think of the word summit, we're actually thinking of a peak, right? Oh, let's do the summit is what Clymer said, right? So we similarly have charted a process in which summit scholars are working up to this. And as part of that, right, is that we place a lot of emphasis in the future of global health, which are the student voices. These are the logos of our great summit partners. Participation from these groups have actively engaged in the discussion and have advanced that discussion, and that's what you're going to hear throughout this summit. As of participants, right now attendees, we had this morning around 460 people confirmed. We almost have 200 people in this room right now, which is extremely exciting. And as you can see, we have representation from many parts of the world, which makes me also very proud to be part of this university. As a broad overview of what we're going to be doing right now, right, we have the 2-day summit and we have a 3rd-day internal conversation to advance the conversation or the topic in decolonizing global health at UMB. But for the purpose of the people that are attending right now, you'll see that the agenda places at the middle of kind of as its main course these hearing from the future interprofessional student panels, in which we're going to be talking to trainees from different careers, and we're going to be trying to extract from them their ideas about what it means, what this topic means for the future of their profession. And then we're going to have expert reactor panels that are going to be talking about what the students were saying, but also bringing their insights and their work into it. I really want to invite you as well to our both keynote speakers, 2 keynote addresses. Following this, Dr. Ijeoma Nodimo Para, and tomorrow, a conversation between Dr. Agnes Binagwahu and Dr. Samba Sow, both former ministries of health in Rwanda and Mali, respectively. And then today in the afternoon, during lunch, we'll have an amazing conversation around the intersections between diversity, inclusion, and diversity, equity, and inclusion, and decolonization. And we have two amazing members of the University of Maryland faculty, Dr. Courtney Jones-Carney and Dr. Thurka Sanguramurthy, that will be speaking to these intersections. So again, I want to welcome you. It's incredibly exciting to be here.